Dr. Sonia, you can start.
We'll start? Yeah. So a warm good evening to one and all present here. And on behalf of IAP Allergy and Applied Immunology chapter, let me take the privilege to welcome all the esteemed faculties present over here, the office bearers of IAP Allergy chapter, office bearers of IAP Ophthalmology, Indian Ophthalmological Society, and all the delegates who have joined us today for yet another informative session on ocular allergies. I'm Dr. Sonia Bhatt, a pediatrician with special interest in pediatric allergies from Agra. Myself and Dr. Madhuvanti Mohan will be the hosts for today's session. Dr. Madhuvanti Mohan is an ophthalmologist, currently a cornea consultant at Allergen Eye Hospital, Chennai, with a special interest in keratoplasty and ocular surface diseases. She's completed her cornea fellowship from Shankar Nethralaya. A warm welcome to you, Dr. Madhuvanti. So all of us who had joined us yesterday already know that we have started a historical journey, a first of its kind, with a mutual collaboration between two very important societies, the IAP Allergy chapter and the Indian Ophthalmological Society. They have come together for a common cause, that is to help people deal with very important problem which we all are facing. There are ocular allergies. So yesterday we already discussed about the clinical presentations, the etiopathogenesis, the diagnostic modalities which are as of now present with us. And today we'll be taking you through the treatment of these diseases, because all of us know that this is a very frequent yet a very debilitating condition, both in adults as well as in pediatrics, where it may present solely but also as a part of systemic illness. So all of us, this has been discussed today, and we'll be taking this webinar forward with the treatment modalities. But before we start the session, I would request my co-host, Dr. Madhuvanti Mohan, to introduce our esteemed guest and the esteemed panel which is present there to enlighten us today. So over to you, Dr. Mohan, for the introduction of our esteemed panelists and faculties.
Thank you, Dr. Sonia, for a very nice introduction. So I would like to start first like to introduce Dr. Nikhil Gokhale. He's a senior cornea refractive surgeon running his own clinic in Mumbai with a very keen interest in allergies. We welcome you, sir. Next, I would like to welcome Dr. Jayesh Vezirani, who is the director of Excel Eye Care in Ahmedabad, and he was trained at LVP Eye Institute. His key interests include ocular allergy, immune-mediated corneal disorders, limbal stem cell transplantation, and lamellar corneal surgery. Thank you for joining us today, sir. And our third panelist is Dr. Bhaskar Srinivasan, a senior cornea specialist and director of Code Eye Care in Chennai. Sir has a special interest in cornea, ocular surface diseases, and keratoprocesses. Thank you for joining us, sir. So let's start with today's session. I would like to invite the first speaker, Dr. Sharon D'Souza. Ma'am is a senior ophthalmologist from Apollo Hospital, Bangalore. She is trained in cornea and refractive surgery with a special interest in eye allergies and a PhD in ocular immunology. She's going to enlighten us about topical therapies in ocular allergies. We welcome you, ma'am. Please start your session.
Good evening, everyone. Thank you very much to Dr. Shweta and Dr. Dheeraj for including me in this wonderful session and seminar. So I hope my slides are visible and I'm audible.
Slides yet to be seen, ma'am. Yeah, see.
Seen?
Yeah, we can see them.
Visible, ma'am,
Yeah. So I'm sure after the extensive sessions yesterday and discussions yesterday, we don't really need to go into the clinical presentations of ocular allergy. And we are well aware that ocular allergy has a very, very varied presentation and can be chronic and recalcitrant to treatment as well. Now, what we have available to us are a number of topical therapies, and it's important to know which topical therapy we need to use when. Now, there are a lot of literature available to us for allergy, and it's amazing that many of the authors on these papers are with us today as faculty, as panelists and speakers, and some of the best in the world. And it's amazing that we have that literature available to us. For anyone interested, please go ahead and read this, and it's really enlightening. But what we need to get from these papers is to understand what is the pathophysiology and where we need to use what medications. Now, I won't dwell too much into this, but we do know that allergy has both an early and a late phase. In the early phase, as shown in this diagram, the allergens are taken up by the antigen presenting cells, which is then presented to the T cell, which gets activated to the Th2 cell and then releases the IgE from the plasma cell. And this IgE moves around, goes back from the lymph nodes, goes into circulation. And when it connects to the mast cell, it causes a degranulation of the mast cell, resulting in release of various mediators, which result in our actual allergic reaction. Now, why it's important to understand the mechanism of the allergic conjunctivitis is because the main cells, the mast cells, the Th2 cytokines, the eosinophils, are all targets for therapy when we are looking at topical and systemic therapy. And it's amazing the number of targeted therapies that are available to us for allergy, and you'll see it through the sessions today. And that's what we need to understand. The early phase reaction is basically a lot of related to the mast cell degranulation and the histamine release, which is responsible for the early phase symptoms like the itching, redness, watering, which we see, and also really an activation of the phospholipase pathway, which results in release of various inflammatory cells and cytokines. Now, both these are very important areas of targeting for our topical therapy. So we must remember this pathophysiology. Now, another thing we need to remember when we are talking about topical therapies is that there are a number of terminologies that are there in ocular allergy. And just to give a quick overview of it, because we'll be talking about it when we are discussing the treatment. So the first thing is the seasonal allergic conjunctivitis, or the SAC, which is a very common form of allergy. It usually, as the name suggests, peaks due to seasonal variation. And the other is perennial allergic conjunctivitis, which, as the name suggests, does not have any particular season and can be present through the year. These are IgE-mediated types of allergy, another point which is very important to remember when we are planning the treatment. The next type of allergy is the vernal keratoconjunctivitis, which is a more severe form of allergy and classically has been described in children and young adolescents with a male predominance, but we do know that we may see it later, we may see it in both males and females. But what we need to remember is that because it's a much more severe form of disease, it needs very often to be treated with a higher level of therapy. The other is atopic keratoconjunctivitis, which, as the name suggests, is associated with atopy disease of the systemic health. And in these children, you can have much more other symptoms of skin or asthma-related changes or other systemic changes. And they need to be identified because, again, it's a much more severe kind of a disease. Now, there are a number of other terminologies which is also important to remember when we are talking about the treatment. One being related to, of course, these seasonal, perennial, and others. But we also need to remember that the grade of disease or severity of the illness is important to take into consideration. So we have mild, moderate, or severe disease based on the clinical features. And you also have acute, chronic, recurrent, or intermittent disease, which is the periodicity of the disease. So intermittent disease is anything in which the patient has an inflammation-free interval of more than 3 months. But a chronic disease is where there are very frequent recurrences and the inflammation-free interval may be less than 1 month, or the patient has a very short period of medications. Now, why we need to remember this is with allergy, we have a step ladder kind of treatment, and all of these factors need to be kept in mind when we are trying to make our decision. This is a very interesting and nice paper which was given by Dr. Nikhil, who is on our panel today, where he divides the severity of allergy into mild, moderate, severe, and also we're looking at the periodicity, which I was speaking about, into intermittent and chronic. Now, as you can see from the clinical pictures, there's a lot of difference between the clinical presentations, and it's important for us to identify these features accurately and take a good history so that we understand the periodicity of it, because the treatment would change accordingly. So what's available to us in our armamentarium for treating these patients? There are quite a few topical medications that are available to us, and I'll just give you a brief overview of it. The most common available are the mast cell stabilizers, which were used quite a lot earlier, but now we stick more to the dual action agents, which have both mast cell stabilizer action and the antihistaminic action, although the mast cell stabilizers were very, very effective. The most common dual acting agents that are available to us is olopatadine, ketotifen, and bipotestin and alcaftadine, which are available in various percentages. Now, based on the percentage which we want to use, the frequency of dosing would change. For example, an olopatadine of a lower strength would require a twice daily dosage, whereas the higher strength has been given for a single day or once a day dosage. Again, once this is relegated to use in very early disease, and I'll be showing some clinical examples for that. But once we have an activation or an acute attack on exacerbation of disease, we do need to add on some form of a steroid. In the milder cases, we have low potency or soft steroids like loteprednol of 0.5% or fluoromethalone. While for more severe disease, we would require high potency steroid like prednisolone acetate or dexamethasone. We also have difluprednate available to us now. However, we know the complications associated with excessive steroid use. So we do have available to us steroid sparing agents like cyclosporin, again available in various strengths, and we'll be discussing that, and tacrolimus, both of which have been found to be very useful in our treatment. So coming back to the stepladder approach, which we were discussing, in the mild disease, where there's just about a little bit of congestion, usually we prescribe the mast cell stabilizers or dual acting agents. Once there are acute exacerbations, you do require some form of a steroid, which is usually a low potency steroid. And as the severity of disease increases, the potency of steroid also required would be increased. And if the patient is having chronic recurrences with multiple recurrences, it's a good idea to put them on a steroid sparing agent, because this reduces the chance of the recurrences happening. And these are cyclosporin and tacrolimus. And once we get into the severe or blinding kind of disease, definitely additional therapy based on the severity is required. So it's important to remember that it's not all about topical therapy in these cases. It's important to understand at which level we are and step up the therapy appropriately to prevent or try to alleviate the severity of this disease and prevent a blinding complication. So let's look at it in terms of our clinical features. So when you have a mild disease like this, which has just about a little bit of congestion, a few papillae, the eye is otherwise fairly quiet, then as we were discussing, it is enough probably to give a mast cell stabilizer or a dual acting agent. You may have to give a very mild steroid for a short duration of time, and we try to keep the steroid requirement as minimal as possible. Mast cell stabilizers, as we were discussing, as the name suggests, prevent the degranulation of the mast cells and thereby reducing the release of histamine. Histamine acts on the H1 receptor and causes the effects or the features of allergy that we have. So antihistaminics along with the mast cell stabilizer reduces the actual clinical features that we have of allergy. So these medications are very useful. However, they are not immediate acting and so need to be given for a little longer time. Once we have a slightly more moderate disease or more severe disease, there may be some corneal involvement in terms of fine punctate erosions. Then in addition to our mast cell stabilizers or dual acting agents, we do need to add on probably some form of a topical steroid, and depending on the severity of disease, you can decide what potency of steroid is required. Now, again, it depends on the periodicity of disease, which we need to keep in mind. So if it's intermittent, then the short pulse of steroid may be okay. But most of the time we have a chronic disease or a recurrent disease, and there we do need to add on the steroid sparing agents, where now tacrolimus has been very, very useful to us in these conditions. So 0.03% is what we usually use, and topically it helps a lot. And of course, depending on if there is a recurrence of the inflammation, then you have to add on the steroid. Now, where in all of this pathway do the steroids act? The steroids act by blocking the phospholipase part of the pathway. Again, that is a very important area which is related to the inflammation which we see on the ocular surface, both related to the lipoxygenase and the cyclooxygenase pathway. So that's what we are trying to block. It is still fairly high up in the pathway. It has a very potent anti-inflammatory effect, but do remember that they come with its own, with their own risks. So we would try to reduce the amount of usage of steroid wherever possible. So monitoring these patients is very, very important to prevent their long-term side effects. Once we go into severe disease, do remember that only topical therapy may not be enough. So we definitely would require a potent steroid when it's a very severe disease in pulse, along with the steroid sparing agents wherever possible, but may require additional maintenance therapy. And that is very, very important to remember. So we've been talking a lot about the steroid sparing agents, and these are basically cyclosporin and tacrolimus, which is available to us as topical therapy. Both of these are calcineurin inhibitors. They're very safe in the long run, has been shown over multiple studies. They act slightly different. The cyclosporin blocks the cyclophilin pathway, and the tacrolimus blocks the FKBP receptor. But both of them result in an inhibition of the T cell activation and cytokine release. And we know it's an inflammatory condition, so there's a lot of cytokine release which happens. So in the long run, it helps with reducing the inflammation on the surface. Between the two, there are a number of percentages available to us. Cyclosporin, ideally, the higher concentration of 1% would be what would be ideal for controlling allergy, but that's not available to us as a pre-prepared solution. There is a 2%, but it is quite irritant to the eye. The lower concentrations are available. They may be useful when the allergy is not very severe. But tacrolimus really has changed the way we deal with these patients and handle them. So 0.03% and 0.1% of tacrolimus, it has been very, very good in controlling a lot of recurrent and chronic allergies. The only thing you need to warn or tell the patients beforehand is that it causes some amount of burning sensation in the eye. So once they are warned, they usually are well prepared and do not discontinue it. Otherwise, they may tend to discontinue the medication. Blinding disease, of course, as I was saying, these are conditions where only the topical therapy will not be enough. And it's very, very important to identify these cases or this stage of disease and understand that we need to do more for these eyes and either take them up for a particular procedure or add on systemic therapy as required. So these are conditions where you have like active shield ulcers or a lot of limbal inflammation, limbal stem cell deficiency happening, which is potentially blinding to the eye. So just to end with one more case, just to show that if we add on therapy, then we can really save these eyes, and even the cobblestone papillae do reduce over time and with treatment. I end with one last very, very important definition or terminology that we need to know or understand in our practice, that of refractory VKC, a very elegant paper given by Dr. Shweta and Dr. Bhaskar, Dr. Geeta Iyer and group, where they have defined the refractory VKC as a form where the persistence or worsening of the disease activity it's not responding to even the highest possible concentration of whatever treatment we are giving, or is either steroid dependent or unresponsive. And this has been going on for more than 3 consecutive months. And why this is important is because by defining this, we do realize when we need to step up beyond our topical therapy. So in summary, prophylaxis in mild disease, topical steroids are effective, but we need to use it with caution and in pulses. Calcineurin inhibitors are useful in chronic disease and prophylaxis, and especially tacrolimus has been very useful. It's important to grade and classify the disease, to plan the treatment, tailor the therapy based on not only the severity, but also the chronicity and safety of medications. Always have a step ladder approach to management. Understand when topical therapy alone is not sufficient, and avoid a delay in transition of therapy to avoid complications both of the disease and the treatment. Thank you very much for your patient listening.
Thank you, ma'am, for such a clear and concise talk on topical therapies. Ma'am, I do have a question.
I think one of the panelists, Dr. Nikhil.
Yeah, I think ma'am's video has
lost. So great. Most of the guidelines have come from the panelists or the faculties present today. So Dr. Nikhil or Dr. Jayesh, anyone if could take this question, it would be really nice.
Yes, I think we've lost Sharon, but it was an excellent talk. So to answer your question directly, they are pretty much interchangeable. We have always been using for many years mast cell stabilizers such as chromoglycate, but nowadays the availability is an issue. So more for that reason than for anything else, we switched over to the dual use agents or the dual acting agents. To the best of my knowledge, there is no evidence to say that one is better than the other, and the indications for both are similar, if not exactly the same. Dr. Nikhil, you have any alternative points of view?
Not really. I think availability has become one of the issues and maybe the dual acting agents have some immediate action as well. Mast cell stabilizers and more of prophylactic effect, whereas the dual have an immediate antihistaminic action plus the stabilization of the cell. So it will have a better effect and more faster effect, and then the maintenance of the effect because of mast cell stabilization. So they have dual advantage sort of thing. So nowadays we tend to use those rather than chromoglycate very often. But there are some patients occasionally where people have tried to use chromoglycate and they seem to be doing well with that drug. So if that's the situation, you can carry on with this.
Thank you, sir. Is there a minimum time period that you would want to give the mast cell stabilizer or dual acting agents for, sir?
No, so basically when the patient comes to us, we need to analyze what is the grade of inflammation and then take a call. So if it's just a seasonal allergy where there's no corneal involvement, just itching and occasional redness, then you can definitely use these agents and try avoiding anything beyond that, maybe with lubricants and cold compresses sort of thing. But when we have situations where the patient comes in with an extremely inflamed eye, then definitely we need to switch to using multiple agents together. So we know these drugs alone are not going to work. So it's only for those very mild situations where there is only conjunctival involvement, you can use them, and maybe that it's not threatening in any way, so you can pull them on longer and see whether they are adequate on their own to sort of reduce the attacks or severity and go on that.
Thank you, sir.
Thank you, sir, for this. Thank you, ma'am, for the elusive presentation. So one question I have, like, what is the biggest pitfall when you use ocular allergy, the long-term steroids, especially in children? What is the side effects or which we should be very much cautious, and how long can we use steroids if, like, obviously we send it to the ophthalmologist only, but how long can these steroids be used, like, if it is not getting controlled with?
So I think basically, yeah. Okay, so basically in the past we didn't have these soft steroids as we call them today. So we used to use betamethasone, dexamethasone or prednisolone, which are much more potent. They penetrate inside the eye, and in children, even as an ophthalmologist, it's easier said than done, but it's difficult to monitor the intraocular pressure. These children don't open their eye very often. So as general physicians or pediatricians, if you prescribe steroids, then I think the problem is that how do we monitor them? And because most of the children that we see in India have chronic allergy, so they don't have those. So we need to identify the pattern. So if you have a child who comes to you with maybe once in 3 or 6 months with a red eye which looks like allergy, you could safely use whichever steroid is available. But if you have somebody who comes to you with a sort of disease which is constantly going on and on, definitely they would need a referral to the ophthalmologist. Maybe you could give steroid as a short-term measure till he reaches the ophthalmic surgeon. But long-term use is definitely what we try to avoid if possible by using alternative agents as mentioned.
And not just the eye drops, even your inhalers and your steroid creams that dermatologists use. If you have to keep the patient on these steroid agents, then you will need to monitor the ocular side effects, because you can develop cataract and glaucoma because of any form of steroid use.
Thank you so much, sir. So after this wonderful discussion on topical therapies, now let's discuss a little about the systemic therapies, including biologicals. And for this, I welcome none other than Dr. Sinchana Bhatt. She's a senior pediatric allergist from Mangalore and a dear friend. And I would invite Dr. Sinchana to deliberate her talk. on the ocular, the systemic therapies and biologicals. Welcome, Dr. Sinchana.
Thank you, ma'am, for the kind introduction. Very good evening to everyone. And at the outset, I would like to thank the Allergy and Applied Immunology chapter, Dr. Neeraj Gupta, especially for giving me this opportunity, as well as the All India Ophthalmological Society. So I'll be speaking on systemic therapy in allergic conjunctivitis. I'll just share the screen. One second. Is it visible, ma'am?
It is, but yet
the screen share.
Screen share is, we can see your screen.
Yes. So I bring in greetings from Mangalore, for the coastal city of Karnataka, and I practice here as an allergy specialist. So the content of today's talk would be, first of all, basic.
Dr. Sinchana, your slides are not
Your
visible.
slides are not visible. We can just see the screen, but your slides are yet not visible.
Oh, is it? I'm sharing the screen now
we
also.
Can just see your...
Okay.
No, we can just see the folders, but we cannot see the
okay,
topic slides as.
Okay. Now?
No. Yeah.
Okay,
now it's visible, ma'am.
Yeah, they are visible.
Yes, now, ma'am.
All good, yeah.
Yes. So we'll be discussing the systemic therapy, basically the antihistamines, the leukotriene receptor antagonists, the steroids, and the biologics. So we all know from since yesterday we have been discussing about this topic of allergies, and by now we have understood that it's a multifactorial disease. It has a varied clinical course, different in each patient. The duration is different, the severity, and it is also associated with other comorbidities such as allergic rhinitis or atopic dermatitis. So most often it is associated with allergic rhinitis, and it is together called as allergic rhinoconjunctivitis. It has a significant impact on the quality of life, especially as pediatricians. We know that the child may definitely suffer when he goes to school, and always seeing the child itching his eyes will be very difficult for the parents and disturbing. So a combination of treatment is needed most of the times. However, what happens is when the patient goes into a refractory stage, it often leads to polypharmacy. And most often we know that our patients are just not satisfied with some topical treatment. They always keep on asking for some syrups or tablets. And what we should know about the evidence for such treatment, we need to definitely know about it. So we know that this allergic reaction has an early phase reaction and a late phase reaction. And the main important cell releasing the histamine is basically the mast cells and the basophils. So in the initial phase, it is the histamine. And because of this, we have all the symptoms of allergy. And later on in the late phase reaction, there are prostaglandins and other inflammatory markers also which are released. So the histamine goes and binds to the histamine receptors which are present in our body, and mainly the antihistamines act on the H1 receptors. So the H1 receptors have functions such as smooth muscle contraction, vascular permeability. They also go and act on the C fibers and cause sensory nerve stimulation, leading on to pruritus. As also, the histamine acts on the H4 receptors, which are mainly present on the mast cells and the basophils. So the histamine is blocked before it binds to receptors, before it binds to its receptor by the antihistamines. So we know that there are first generation antihistamine, second generation, and now we also have the third generation. So what is the difference that the first generation antihistamines usually cross the blood-brain barrier, and hence they cause more of side effects such as sleepiness, confusion, urinary retention, and also the muscarinic effect also causes these symptoms, and the dryness worsens, especially in children with allergic conjunctivitis. When they have a dry eye associated, these antihistamines may further worsen the dry eye. So they are no longer recommended for use. Coming on to the second generation antihistamines, we have a whole lot of them in our basket. So they have a very high H1 receptor selectivity. They do not cross the blood-brain barrier. They have a longer duration of action. That's why it is possible for us to give it even once a day. And the adverse effects are also lesser. And we know that though the adverse effects and the dryness is lesser, however, there are studies which have shown that cetirizine and loratadine, they can worsen the dryness, ocular dryness in some patients. So we have to be careful with that. So this is the IACI position paper of 2019, which is a beautiful picture which depicts the summary of basically the management of allergic conjunctivitis. So it goes on from seasonal to perennial to VKC and to AKC. So we know that the base of it, we know that here we have to always keep on avoiding the allergens, the exposure. The lubrication of the eye is a very important aspect, and also protecting the eyes from the exposure to environmental triggers is also very important. However, if we see the third part of the third step here comes the role of oral antihistamines. So it is very clearly mentioned that when there is an extraocular allergy associated with conjunctivitis, that is the time we are justified in using oral antihistamines. That means if a person has rhinitis, or if a person needs it for atopic dermatitis probably, then it is always better to use oral antihistamines. Otherwise, the topical treatment, as ma'am mentioned in the previous talk, is the first line of management of the eye allergies. So as we go on to the next drugs, we'll see that where they can be used based on this position paper itself. So this same article mentions that oral antihistamines are frequently used only in ocular allergies which are associated with comorbidities, as I said, in rhinitis. So loratadine, they have told that loratadine, desloratadine, and fexofenadine are the highly recommended drugs for allergic rhinoconjunctivitis when we want to use the oral treatment. And they are also useful in the refractory cases of VKC, or the vernal conjunctivitis, and atopic keratoconjunctivitis. So if we see again in the the part which is top, that is in the recalcitrant cases, there we can go ahead with the oral antihistamines when the patient is not symptomatically better. So we all know there are three generations now. The first generation is not being used any longer because we have very good second generation and third generation antihistamines. So here we have a whole this one gamut where terfenadine and astamizole is no longer used. So we have most commonly used are loratadine, ibastine, cetirizine, levocetirizine, bilastine is the newer one, and also the fexofenadine, which is again a metabolite of the terfenadine. So desloratadine and fexofenadine and levocetirizine are the third generation. Now, which one to choose is a very important question. So here, if we see these are the doses. So cetirizine can be used right from 6 months of age. Again, when it comes to levocetirizine, the dosage is half the dose of cetirizine. And again, loratadine can be used from 1 year of age. Fexofenadine can be used again from 6 months of age. So bilastine from 6 years onwards. That is the this one. So if we ask this question, all oral antihistamines have similar efficacy except rupatadine. So the choice of the oral antihistamine depends on the availability and the cost factor. So this is a very important takeaway that when we have to choose, we have to also consider the availability and the cost factor for each patient. And also the if we see some patients definitely complain of sedation with cetirizine and levocetirizine. So whenever we prescribe, we should ask this question to the patients that whether they get sedated and then accordingly especially for people who have to, they have a very hectic duty in the morning, or when even in kids when they are going to school, they cannot afford to be sedated. So that is why these factors need to be considered. So that is the role of oral antihistamine. So they have reviewed even rupatadine, which I told, and this is a systematic review of 4 randomized controlled trials where they have where they have compared rupatadine versus Avastin versus placebo. In one of the trials they have compared rupatadine versus loratadine versus placebo. So when they've just seen that the improvement of ocular symptom was more in rupatadine compared to a placebo. So that means that most of the antihistamines are almost similar in nature. Now coming on to the very commonly used drug, that is the leukotriene receptor antagonist. We are all very much carried away with the combinations which are available. The representatives also keep on coming and keep on telling us to use these drugs, which are always, most of the times we don't get plain leukotriene receptors. It is always with the antihistamine. So whether what is the action of this and what is the importance of it in ocular allergies? So leukotriene receptor antagonists have a very slower onset of action. They prevent the binding of leukotrienes to the conjunctival receptors. However, they are less effective. Again, the point comes into what is important is that topical treatment is the first, this one. This is less effective than the topical treatment and also the oral antihistamines. So this is all based on evidence, and the studies are still required to know the benefits of a combination of leukotriene receptor plus oral antihistamines. So we are not, there is no added benefit by adding a leukotriene receptor antagonist with a oral antihistamine. So there is a very limited role in the management of ocular allergies. So this was a meta-analysis which was done and it was published in JACI practice, and they have combined, it was a systematic review and meta-analysis of 18 trials which basically compared leukotriene receptor antagonists with the placebo. So here we can see the forest plot, and first one when they have seen between LTRA and placebo, it was the LTRA which was better. However, when they compared LTRA and antihistamine, the antihistamine alone was better. So again, this proves the point that standalone anti-leukotriene receptor antagonists are not very useful in allergic conjunctivitis. Coming on to oral steroids, again, whenever there is an inflammation and if everything runs out of our kitty, we always resort to oral steroids. A short course may be probably beneficial in allergic conjunctivitis or refractory cases of VKC and AKC, only in very hyperacute exacerbations, depending case to case and also based on the ophthalmologist's decision, probably not to be used, and very carefully. Only a short course may be this one, but not as a first line, definitely. Coming on to the biologics, which is the new this one trendsetter in allergy, field of allergy, and everyone is talking about it, whether we can use it in ocular allergies is a big question. So we all know that there is both IgE dependent allergic inflammation and also a non-IgE dependent inflammation in allergic conjunctivitis. There is a whole lot of inflammatory inflammatory cascade which is going on, a lot of cytokines released, and we all know that IL-4, IL-13 and IL-5 are the most important cytokines which actually mediate allergy. So we have molecules, we have biologics against them, and there are many other upcoming biologics as well, which I may not be discussing in detail as such. So this is a corneal surface. What happens is as the conjunctiva gets inflamed, the cornea also gets affected, and then there are receptors on these as well, which the inflammatory markers are there, which and the biologics can act over there as well. So coming on to the omalizumab, which is the anti-IgE antibody, monoclonal antibody or the biologic. So basically, we know that it blocks the free Ig and also goes and binds to the very high affinity IgE receptor. So thereby it reduces the allergic inflammation. So this is the role of omalizumab, and it has been approved already in difficult to treat asthma cases and in urticaria also, in those which are refractory to our antihistamines. So this is approved more than 6 years of age, and the dose is based on the IgE levels and body weight. Like yesterday, Dr. Neeraj Gupta sir was discussing, there is a formula of 0.016 K into weight into total Ig, maximum of 300 mg, and it has to be given every 2 to 4 weeks. From 3 months to 12 months is the total duration of action. So it is given subcutaneously. So what has the literature shown? What has the evidence shown? They have seen there are few case reports on adults with VKC and AKC where even a single dose there has been improvement. So, but however, in children, in 1 in 4 children have not improved. So it has reduced the symptom scores, and it has a steroid sparing action as well. Effects were, however, short lasting. But we need larger clinical trials in AKC and VKC to know the duration, to know the efficacy. So definitely it has a role in recalcitrant cases, but again, based on case to case, where all the other medications we have reached the highest limits, that is a time when we may resort to this medication. Again, coming on to dupilumab, which is an anti-IL-4 or anti-IL-4-13, IL-13 inhibitor. So few cases of refractory AKC and VKC have been treated successfully with dupilumab. It can be used, it has been approved in atopic dermatitis. So it can be used when there is concomitant AD. However, we have to be careful that it can sometimes exacerbate eye symptoms, especially when they are used for atopic dermatitis. So we have seen that cicatricial ectropion that has been reported. So it may not be an ideal choice for AKC when it is associated with eyelid eczema. So this is about dupilumab, and then we have other biologics as well, like mepolizumab and reslizumab, which act on the IL-5 receptor and the IL-5 receptor, IL-5 also. So however, there are a lot of studies which are required for basically knowing its role. So that is, so indications of biologics are when there are severe chronic symptoms, patient is not able to tolerate, and he's non-responsive to maximal topical therapy, and there is significant corneal involvement probably, and systemic allergic diseases associated with the conjunctivitis. So coming on to the take-home messages, oral antihistamines to be used only when there is an associated comorbid condition such as rhinitis, refractory cases of atopic conjunctivitis or atopic vernal keratoconjunctivitis may need oral treatment, and usually the second generation antihistamines need to be used, and they are the preferred choice, and it has to be based on like I said, the what is the cost effectiveness and also the availability. The leukotriene receptor antagonists have a very limited role, has to be used very carefully, especially with the black box warning which has been given by the FDA on Montelukast. So careful usage. And biologics may be used in refractory cases, again based on case to case this basis. However, more robust studies are needed, so it should not be used very misused probably. So that is the this one evidence on systemic therapy in ocular allergies. I would like to mention Dr. Neeraj Gupta sir here, who had given me a few slides on biologics. He had delivered a very nice talk on ocular biologics and ocular allergies, and I'm thankful for that. And even Soumya ma'am, who has also written an excellent this one, and she had helped me out. Thank you so much, sir and ma'am.
Thank you so much, Dr. Sinchina, for such a wonderful presentation. So, yeah, you have made many things clear, but I just have a question for the panel that though you have mentioned that leukotriene antagonists do not carry, has a limited role, I just like to ask that in your practice or in your experience, where do you find it useful? Because biologicals are still coming and we don't have much practical level. How much usage do you find in your practice? So, Dr. Bhaskar sir or Dr. Jayesh sir, anyone who could take the question, please.
I think biologics we've not actually used much. We're just kind of getting into it, trying to understand the indications and usage. Also, the cost does play a role as far as biologics are concerned. With the usage of topical tacrolimus, to a large extent, most of our allergic conjunctivitis, we've been able to get them off topical steroids, and topical tacrolimus has worked reasonably well as far as allergies are concerned. In that recalcitrant group, we've kind of shifted to using systemic tacrolimus or systemic cyclosporin as immunomodulator. And in some cases where there's significant papillary changes, we've opted for surgical excision. So of the papillae along with mucous membrane grafting, which we did publish a couple of years back, because we do believe the mucosa also has some immune tolerance, which adds on to the ocular surface stability in these eyes. But the recent literature that's coming with the use of systemic immunosuppression for a longer period of time also seems to be showing the same result with respect to decrease in the papillary size and control of the inflammation. And some of the recent publications on the biologics have also showed an improvement in the papillary size and improvement in the allergic symptoms. So that's still a zone where we still probably need more data to give very clear guidelines for both the allergy specialists and for the ocular allergy specialists to kind of work in sync to decide and give a guideline in terms of where you would want to use which molecule, whether with respect to the biologics, the immunomodulators, or even the desensitization therapy as such.
Okay, thank you. So we have a question from Dr. Soumya, and she's asking how long can topical tacrolimus be used in such conditions?
So the longest reported use of topical tacrolimus is for years. This may not be for ocular allergy, but for other indications, and it is very, very safe. So I don't think there is a hard time limit to it, because once you use it, you have to use it for at least a few months for it to take effect. And especially for the recalcitrant forms of ocular allergy, like VKC and AKC, we do use it for 6 months to a year, sometimes even more than that. So I just wanted to make a point about the use of systemic therapy in ocular allergy. So I understand that for a pediatrician or for a physician, allergic conjunctivitis is allergic conjunctivitis and it is red eye. But from our perspective, if you look at seasonal or perennial allergic conjunctivitis, they are completely different to VKC and AKC. And the kind of manifestations we see, the kind of effects they have on the eye in terms of scarring and impact on the child or the adult, as the case may be, are very, very different. And likewise, the treatments are also very, very different. So rather than, lumping the treatments into treatments for allergic conjunctivitis, it would be much better if we speak in terms of treatments for SAC and PAC versus treatments for VKC and AKC. So things like cetirizine or oral antihistaminics work very well for SAC and PAC. But for VKC and AKC, especially those which are very long-standing, chronic, which have blinding effects on the eye, there's not much evidence for that, and neither does it work in real life. About omalizumab, we don't have enough data. We're looking forward to it. But the few patients that we have seen, it seems like the effect, as Dr. Soumya mentioned, is transient. It is short-lasting, and it is quite expensive. So those are the concerns. Whereas, as Dr. Bhaskar rightly mentioned, and I'm sure Dr. Sain Basu is going to elaborate on this, systemic therapy with T-cell inhibitors seems to be much more durable and effective, and also cost-effective for these patients who have very severe ocular allergy.
Thank you so much, sir. And now we move to the next talk after Dr. Sinjina's wonderful talk. So something we have discussed the pharmacotherapeutics, and what we always wonder is there any chance, be it parents, be it physicians, pediatricians, or allergists, we always wonder on one thing, that can we convert an allergic child into a non-allergic side, or the atopic to the non-atopic? And this is what we are going to discuss now. And for discussing this very important topic, we are fortunate to have Dr. Soumya Nagarajan with us. She's a very senior pediatric allergist and a leading voice in the field of in this field, and an internationally renowned figure. She has a European board certificate in allergy and immunology. She has multiple fellowship in allergy and immunology from NUS Singapore, and she has been a very leading personality in this research field. So we would welcome Dr. Swamya ma'am for allergen immunotherapy for ocular allergies, efficacy and indications. A warm welcome to you, ma'am.
Thank you, Dr. Sonia. And I hope my slides are visible.
Yeah, they are visible. I think you can just make them a little big with the slideshow, ma'am. You can put them in the slideshow mode.
Yes, is it in the slideshow? Yeah,
Yeah.
thank you.
Yeah, visible.
Thank you for the warm introduction. And at the outset, I would like to thank the IAP Allergy and Applied Immunology chapter and All India Ophthalmic Society for this excellent initiative. And after my previous excellent speakers, I think we go beyond pharmacotherapy. And it's my privilege also to have worked very closely with Dr. Sharon and other leading ophthalmologists from the team of Narayan Nethralaya in Bangalore as well. So few of the concluding slides about our data and the on allergen immunotherapy in allergic eye disease is also courtesy Dr. Sharon and her team. So beyond pharmacotherapy and avoidance measures which we have learned from the excellent speakers yesterday and today, I think patient education, beyond which we also have an armamentarium in the allergist basket where we can promise them good disease control with needing for decreasing pharmacotherapy over a period of time and probably also keep their long-term complications of ocular allergies also under control. So what is allergen-specific immunotherapy? It's a practice of mainly administering increasing amounts of allergens to the patients to which they are sensitized to in an order to achieve hypersensitization. Basically, we are reducing the symptoms from the natural exposure to the allergens. Contrary to the belief that immunotherapy is quite the new kid on the block, the data dates back to more than a century back. In the early part of the last century by Dr. Noon, where initial empirical attempts were made with the aim of vaccinating against some hypothesized aerogenic toxins. Fast forward, I think, in the recent past from the subcutaneous immunotherapy, which is, we have more data on the immunotherapy where the patient is injected with the increasing amount of allergens. And given the scenario that we would be coming probable side effects associated with subcutaneous immunotherapy, there were other routes of administration of allergen immunotherapy explored. And from the later part of last century, from 1980 onwards, where there was some associated side effects from SCIT, especially in the Europe, sublingual immunotherapy gained more momentum and has more followed up with more robust data, which we will see in the subsequent slides, along with other oral immunotherapy, mainly for foods, or epicutaneous immunotherapy, or intralymphatic immunotherapy. But in the context of ocular allergies, we'll be touching base only on subcutaneous immunotherapy and sublingual immunotherapy. The first randomized control of SCIT was in 1954, and over a period of time, it has been shown that definitely it does have an impact on the natural history of respiratory allergies and also then in the Hymenoptera. What about sublingual? So as mentioned, I think the first trial for house dust mite, which is the most commonest allergen which we see in allergic rhinoconjunctivitis, the data has been more robust from then on, and from the initial studies after about 1980s, I think 25 years later, the FDA approved SLIT tablet for 3 products in the recent past. So also it has been explored as a therapeutic option in the genome from last 7 to 8 years. Going forward, how does allergen immunotherapy work? We have all heard about the pathophysiology since yesterday and my earlier speakers today. Given that we know that allergen exposure predisposes the patient mainly to Th2 pathway and thereby causes the release of other chemical mediators such as histamine and other mediators of which pharmacotherapy forms the basis. But in allergen immunotherapy, the T regulatory cells is of utmost importance, where it predominantly shifts the allergic pathway from Th2 pathway to Th1 pathway, thereby increasing chemical mediators such as interferon gamma or IL-10, which stimulates the B cells to produce IgG4 or mucosal IgA bar IgA2, which compete with the IgE, which is the main mediator in an type 1 hypersensitivity reaction, and thereby increases the production of the chemical mediators which was seen in early phase and the late phase over a period of time. So mainly it is shifting from Th2 pathway to Th1. And allergen immunotherapy has been the only modality which has been shown to alter the natural course of the disease. It holds good true for ocular allergies as well. So can we do any prognostic testing like a skin prick test we heard yesterday or a serum specific IgE? How long does the immunotherapy take to reduce the sensitization pattern, what we would have seen on the skin prick test or a serum specific IgE, and how soon does it start acting? So generally, as we see, this IgG4 or IgA just starts immediately within the first few weeks after starting allergen immunotherapy, and that continues to grow. However, the skin prick test or the serum specific IgE takes a few months or years also to reduce. Even if I start oral immunotherapy, the allergen immunotherapy in the form of sublingual immunotherapy or subcutaneous immunotherapy, I wouldn't be depending on the skin prick test or the serum specific IgE for me to know the efficacy of the allergen immunotherapy because they would still remain positive. So it is mainly the clinical response which we are looking at. So in the era of evidence-based medicine, where we talk about targeted therapy or the precision therapy, here I think allergen immunotherapy is the modality in allergy practice where it has targets on the mechanisms and the etiopathophysiciology. And it definitely, especially when we select the patients properly and the proper allergens for allergen immunotherapy, the outcome is usually favorable. So what are the indications in the context of ocular allergies? Mainly, as we have heard from our array of panelists and the speakers from yesterday, I think ocular allergies would have association with other allergic disorders, especially allergic rhinitis. So I think optimization of treatment of that particular atopic disease and the allergic rhinitis or rhinoconjunctivitis diagnose patients with evidence of IgE sensitization, be it the sensitization on the skin prick test and or serum specific IgE, and the symptoms must be correlating with the implicated allergen exposure. So if somebody has dust mite sensitization, be it on the serum specific IgE or the skin prick test, I would go back to the second history to try to correlate and try to correlate the symptoms. And if the patient has been on the moderate to severe spectrum despite regular and appropriate pharmacotherapy and probable side effects of the pharmacotherapy also, and if they're disease control and they're not willing for long-term pharmacotherapy, I think these are the ideal patients, especially in the context of ocular allergies, which we would definitely choose for. And for us, the peak flow meter, just to make sure that there is no lower airway involvement, we must make sure their disease is under control. What about the efficacy? So the data has been very robust. Generally, the duration of immunotherapy is recommended 3 to 5 years. It is because anything below that has been shown that the long-term benefits, especially in the IgG4 or the IgA, is very transient and it would reduce rapidly upon the lower duration of treatment. So across the studies, they have found that 3 to 5 years is the long-lasting, is a period where even after stopping immunotherapy, there would be continuation of the effect of allergen immunotherapy. It also prevents newer sensitizations, meaning prevention of development of newer allergies. The sublingual immunotherapy has been of more interest in the recent past, and definitely the symptoms and medication score has been reduced and has moderate level of evidence for slit efficacy in asthma, allergic rhinitis, and rhinoconjunctivitis. What about SCIT? SCIT also has shown that there has been reduction in the 30% in scoring from updosing to maintenance in clinical practice. So in a nutshell, both subcutaneous immunotherapy and sublingual immunotherapy are more favorable, but sublingual immunotherapy is used more favorably because of the associated usage can be given at home and the adverse effects are very minimal. Because SCIT has been shown that local reactions are more common. Those systemic side effects are very less. Local reactions in the form of hives or angioedema can occur within 30 minutes to few hours later. And large local reaction do not predict systemic reaction. Systemic reaction is very less. So the more favorable, especially even in the pediatric population, is sublingual immunotherapy, where the most of the these adverse effects could be only local oromucal pruritus, because it is administered under the tongue, held it for few minutes, and then swallow. And systemic reactions are very, very rare, even as compared to sublingual immunotherapy. Are there any biomarkers we can predict? So generally, though IgG4 ratio to serum specific IgE has been the mainstay in research, but in clinical practice, it's very difficult. So we generally go by clinical score, visual analog score, or total symptom score, or the medication requirement, frequent exacerbation, among others. Though basophil activation test or other chemokines which are specific to T regulatory cells are more to research. So mainly I think we have subcutaneous, sublingual, or we are moving towards more specialized products such as allergoids or recombinant allergens in subcutaneous. I think the favorable data is more favorable for sublingual immunotherapy. So I was fortunate to be one of the co-authors for the position paper on immunotherapy for ocular allergies, which was published earlier this year. And our data, mainly we presented this, the role of immunotherapy in severe ocular allergies in YAKI in 2020, and following it up with the data this year, which is due for publication, along with Dr. Sharon, who presented the talk earlier. So in this cohort, 805 patients with allergic eye disease were included, and 121 patients with refractory eye allergy were referred for allergy evaluation. And after skin prick test, appropriate patient selection, we selected about 52 patients who were started on allergen immunotherapy. And even we had poor response in about 3 of them. But I think this showed that there was definitely decreased the duration of steroid usage, oral steroids, topical steroids, and topical immunomodulators. And it helped them to achieve better control of their symptoms and the number of acute exacerbations. I find, as my esteemed ophthalm colleagues were mentioning earlier, I think topical tacrolimus would definitely help keep the disease under control. With allergen immunotherapy, even systemic therapy also we would be able to stop. So again, thank you. Thank you for a very patient hearing, and thank you for the opportunity.
Thank you so much, Dr. Soumya, for this very informative and enlightening session. So here again, data show the efficacy, and it was so nice to see that you all have already published and for this kind of papers. So again, question to my panelists, like in practical situations, where do you find that this immunotherapy is really helping these cases of ocular allergy? And how often do you have to go to this allergy, or the topical tacrolimus, calcineurin inhibitors are enough to control the disease?
Dr. Sharon.
Yeah, if Dr. Sharon,
I'll
Dr. Sharon, please, will be.
Right. So, excellent talk, and it's been wonderful working with Soumya on this work and for these patients. So, what is interesting is that actually it's a very broad range of patients who benefit from immunotherapy, and what we found over time, and this is after a very long time of using or understanding. It took us some time to understand also which patients would benefit. It's not necessarily the more severe ones or the severity was not really the criteria. It was more to do with the ones who were coming back with recurrent episodes or chronic episodes. You can have a patient who is fairly mild when you're looking at it, but they keep coming back, or they may be steroid dependent, not coming off steroids. So even those we have referred to Dr. Soumya, and then after her evaluation, if she found that skin prick test was positive and her criteria, they have been started on immunotherapy, and even in those conditions, it does help to get them off a steroid. So these were patients who were already on the topical tacrolimus ointment. So, it's not necessary that we are referring before. So you try whatever you can with the topical medications. And in spite of that, if you're finding that it's not helping, or they're still coming with recurrence, or that it's a more severe disease, then it's a good idea that these people may benefit from it. So don't wait till it's very severe, and then that's probably beyond even allergen immunotherapy, and you'd need the other systemic therapy. So it's a good idea to start early. As Dr. Soumya was saying, it has shown to switch the disease, bring them back, change the pattern of allergy, or reverse the severity of allergy to an extent. So
I have a question actually. So we all often come across skin prick test result where the parents come to us and show us that they can't eat anything left now. I attended one of the allergy meetings in Bombay, which was from all specialties, and there I met some people who are from some company. I have no financial interest, who are saying that they have these testing with ELISA for IG reactivity. I think they're called Polestar and Alex and some of these companies, where they reduce the cross reactivity. So they say that, for example, 10 foods may have a single protein which is giving us a positive allergy test. But if you eliminate that protein, maybe the real allergen can be picked up from amongst these 10 food items. So something like that. So I want to know what is the role, because I don't know practically, and they're quite expensive tests, but whether they will be more useful, and because it's very difficult to decide what is the exact allergen that you want to treat when you do a slit or a skit or whatever, option. So if you
Sir,
can
I'll take that
enlighten.
question. Yes, sir, I'll take that question, sir. So thank you. Sir, again, the skin prick test, again, we depend on what is the patient's symptoms. We decide to choose the allergens. The downside of the serum specific IG when it's a blood test, companies run panel tests, which can be a mixture of both aeroallergens and food, and which may be quite confusing. Contrary to, because if it is just positivity on a skin prick test or a blood test, doesn't mean that the patient is actually allergic. We just tell them only sensitization. I go back to the second history, and if the patient is already eating those foods without any issues, we wouldn't tell any avoidance of that particular food at all. Coming to the question of cross-reactivity between a food and the aeroallergens, which is the more interesting allergens in the context of ocular allergies, we see more of in allergic rhinitis, and that is something oral allergy syndrome. The eye involvement would be very minimal, sir. So again, cross-reactivity between food and aeroallergens, which is of implication in ocular allergies, is very minimal. And these patients wouldn't benefit at all from the avoidance of that particular food. And I wouldn't rely much on those tests at all, sir.
Thank you.
Thank you, sir.
Thank you, Dr. Soumya ma'am, for this excellent session on allergen immunotherapy. Now, let us discuss about systemic immunomodulators, for which I would like to invite Dr. Sayan Basu. Dr. Basu serves as the director of both the Professor Brian Holden Eye Research Center and the Center for Ocular Regeneration at LV Prasad Eye Hospital. Clinically, he specializes in high-risk corneal and ocular surface cases, including those with prior surgical failures or complications. We welcome you, sir.
Thank you, Madhuvanti, and thank you to the Indian Academy of Pediatrics and also the All India Ophthalmological Society for this collaboration. I think it's much needed. I think more we have this kind of a crosstalk between different specialities, the more everybody gets to learn, and we can improve and better the ways in which we are managing our patients. So I'm going to talk to you over the next 15 minutes or so over systemic immunosuppression in allergic eye disease. It's a fairly unique topic because it's not something that is practiced very commonly, and there are only few people who use this modality. And I'm just going to first of all set the context of where systemic immunosuppression is indicated, and then what are the outcomes when you use it in the right way, and then discuss and maybe take questions on this topic. So typically, patients with allergy, either they are being treated well and they have no problems, or they are unhappy. Many patients are unhappy, particularly those with chronic allergy and with recalcitrant disease. And sometimes you'll have patients like these, this 14-year-old boy who has had symptoms for the last 8 to 9 years, and the parents are tired of putting drops and they want the allergy to go away. And they have been told since many years that, it's only a matter of time when the child grows up, the allergy will disappear, and they're waiting for the day, and the day has not come. One other thing I think one of the previous speakers also mentioned, which is very important, is that because most of your patients with at least ocular allergy are children or adolescents, you are not just treating the patient, but also treating the entire family, especially the parents who are very anxious and apprehensive. So they're coming with high hopes. They have been to a lot of places and they're not finding solutions. So in the previous case, you saw a very chronic case of severe tarsal papillae. This is a patient with another variant of chronic VKC, like Sharon was talking about, of limbitis or limbal inflammation. You can see this white opacity that is covering the superior limbus, the superior part of the cornea. This is a 9-year-old boy who's had symptoms since the past 3 or 4 years. Again, parents are concerned about the duration of the therapy, the constant need for eye drops, and the symptoms not abating, multiple recurrences, and also now with the concerned about the cosmetic ungainliness appearance of the eye with this whitish opacity, which is not going away. And this is again a very severe advanced case of a 15-year-old boy who also has allergic rhinitis, dermatitis, alopecia, and asthma. So multiple manifestations of atopic disease, and has had these symptoms for the last 10 years, and it's just getting worse, and is using a separate set of medications for each of his different types of allergies. So he's on eye drops for his eye allergy, he's on nasal sprays for his rhinitis, he's using skin creams for his dermatitis and alopecia, and he's also on inhalers for his asthma. And the final case is a 7-year-old boy who's had symptoms, severity or exacerbation of symptoms since the past 3 years, and has now this severe thickening and excoriation of the lower eyelid skin, as well as the eye issues. And he's been to several ophthalmologists already, and this is not going away, or this keeps coming back, and they're looking for solutions. So the context essentially that I wanted to set is that I'm talking about patients with this kind of a chronic and severe presentation. We are not talking about patients with seasonal or perennial allergy, which is only Ig mediated, fleeting, and can be treated very well with antihistaminic or dual action agents, which probably may require a very short course of topical steroids, and they're fine with that. These are patients who have, allergy, the vernal variant of ocular allergy, which is most common, and typically have a chronic course. So the immunopathogenesis, I'm sure, always gets talked about, must have been discussed yesterday. And we talked about this yesterday as well. So in VKC, it's difficult because it's a combined process. On one side, you have the humoral immunity, which is IgE mediated, which is common to the pathways that we see in seasonal and perennial allergy. But you also have the cellular pathway, the Th2 mediated, which leads to these kind of structural remodeling and chronic tissue changes, which later result in limbal damage and keratoconus and other problems in patients with chronic VKC. So whereas what is on the left side is responsible for the acute symptoms, which are relatively easier to treat. The chronicity of the disease is basically what becomes very challenging and is very, very difficult to manage. If you look at the natural history of ocular allergy, and this data is from a study that we did of 26,000 patients of ocular allergy. This was, I think, a 10-year study looking at who are the people who are presenting with allergy, how long is the duration of disease, and so on and so forth, looking at both the prevalence and incidence. And if you look at this chart, what you have on the x-axis is age in years. You will see it's a disease that mostly starts in early childhood when the child is about between 3 to 5 years of age. And it starts to go away during adolescence, which is a good thing, that it is self-limiting. But the problem essentially is that if the hump is very, very wide, which means that a child can, particularly if they have VKC, have the disease for anywhere between 5 to 10 years. And that becomes a problem because the more chronic the disease is, the more likely that they will require multiple courses of steroids. And the more steroids they use, not only can they become dependent on it, but they can also start developing side effects. So steroid response, one of the interesting things about steroid response in the eye is that it is also dependent. There is a natural predilection, but it also depends on for how long you have been using it. So if you use it very often and for very long, anybody can become a steroid responder. Luckily for us, most allergy is very mild and it doesn't really cause a problem. So most patients will require maybe a short course once in a year. And in our study, which like I said, very large study involving 26,000 patients, we saw that the prevalence of sight-threatening allergy, ocular allergy, was only about 1%. And therefore 99% of all allergy is really not sight threatening and can be managed at the general ophthalmologist level. We'll have very few episodes and recurrences, and it is this 1% that we are worried about. And in this 1%, the interesting thing is that the complications that happen in these patients is a combination of the chronicity of the disease, like, for example, limbal stem cell deficiency or keratoconus, which occurs from chronic eye rubbing. And the other complications are actually complications from the long-term use or recurrent use of topical steroids. So like, cataract or glaucoma. Glaucoma is particularly challenging because this is a form of glaucoma that is very difficult to treat. So in recalcitrant disease, and this is the operative word here, which is very important to understand, or refractory VKC, as Shweta and her group very nicely have defined. This is where the role of systemic immunosuppression comes in. So in this 1% of patients, this 1% for us who are working at tertiary care centers is 90% of our cases, because we get a lot of referrals of patients with chronic recalcitrant refractory disease. So our practice is very different, I think, from the practice of a general ophthalmologist who's looking at maybe the milder forms of allergy. We see a lot more of these. So here your options, in addition to the topical therapy, because they're already using this, ranges from using oral steroids, to referring the patient to an allergist for omalizumab, and something that comes in between are oral calcineurin inhibitors, which is cyclosporin and tacrolimus. So that's basically what I'm going to talk about today. So why is this, what is the role of calcineurin inhibitors or cyclosporin and tacrolimus in treating chronic VKC? Is that it basically is very specific for the pathway on your right that we talked about, the Th2 cell-mediated pathway, which is responsible for chronicity. They're very specific for, attacking or targeting this pathway, and that is why their utility in chronic recalcitrant disease. So we have been using this modality for the last many years. The study that I'm going to talk about today, which we published, was for patients who we treated between 2016 and 2024, so over an 8-year period of 27 cases, 54 eyes. The duration of allergy before we started treating them, they was a median of 6 years. So long range, but median of 6 years. So you can see again, chronicity is very important. And these cases were chosen either 85% or 23 cases were because they had recalcitrant disease, and 4 cases because they were known to have steroid response. So in these patients, we could not give them any more topical steroids. The dose that we usually use in these patients, usually you start at a dose of about 4 to 5 milligram per kg per day, and then bring it down to about half of that, between about 2.5 milligram per kg per day. In this study, we used only oral cyclosporin, and of course, you can use oral tacrolimus as well, which we use more and more now. Like most ocular allergy, most of these patients were young males, and they mostly had mixed form of VKC. The limbal form is not as common in India, but you see it more relatively more commonly in patients who have chronic allergy. And many of these cases already had limbal damage and were developing limbal stem cell deficiency, almost half of them, and about 20% also had cataracts, which again are indicators of the fact that they had chronic disease, and not only were they developing the tissue changes of a chronic disease, but also developing the drug-induced complications or steroid-induced complications. This is what was the treatment that they were on before we started oral cyclosporin and after. So the main thing to note here is the use of steroids, which you will see that before this was started on cyclosporin, almost everybody was on some form of steroid, either topical or oral. And after giving them cyclosporin, the need for steroids mostly went away. So the analysis basically showed that before the use of oral cyclosporin, these children had 42 episodes needing the use of topical steroids over a period of 403 months, which reduced to only 10 episodes, which is basically a 1/4 reduction over a period of 250 months. So the odds of developing an acute episode which required the use of topical steroids was 2 times higher if you did not use oral cyclosporin. The additional advantages, which was also a very interesting finding from this study, was that those patients who used oral cyclosporin continued to have disease remission or no acute episodes after they had discontinued oral cyclosporin use, and there was no progression of the pre-existing sequelae noted in these patients. These patients were given oral cyclosporin anywhere between 6 to 18 months. So I'll show you some examples, and these are the same cases that I showed you in the beginning. This is the first case where the child had these very large, ugly-looking papillae, giant papillae, which Bhaskar was talking about. And this is the same case with the use of oral cyclosporin. You can see that the papillae have completely disappeared, and the tarsus now is the inflammation has resolved, and you can only see micro-inflammation there. With use of topical cyclosporin, with the use of oral cyclosporin without topical steroids. This is the other eye of the same patient. I did not show this photograph before, but here again you can see these giant and very inflamed chronic papillae with this ropey discharge, which is trapped between the tarsal papillae, which is again completely regressed with the use of oral cyclosporin over a period of 3 to 6 months. This is a patient with the limbal opacity and developing on its way to developing limbal stem cell deficiency. And this is the response post oral cyclosporin. You can only see very limited scarring in that area. The inflammation is completely gone, the opacity and thickening has completely disappeared. And this is the more dramatic case of essentially the patient had what looked like a fungal ulcer, but luckily there was no infection. It was just a very severe case of a shield ulcer, a very large shield ulcer and very chronic shield ulcer. And in this patient, again, in addition to giving oral cyclosporin, we debrided the ulcer, no steroids. And this is the same patient after months of use of oral cyclosporin, which shows not only resolution in the tarsal inflammation in the papilla, but also in the corneal opacification, which has and the corneal inflammation, which has completely gone away, and the patient's obviously the vision has also remarkably improved. And the last case where you had this 360-degree limbitis, the Horner-Tranter spots, you can see these areas of inflammation, the corneal epithelial irregularity, patient developing an epithelial defect, which again has completely resolved, and you can see how quiet the ocular surface is with the oral cyclosporin use. And this is another case where you can see peripheral inflammation in almost threatening to involve the center, and then the same case with the resolution. This is a case that we had initially planned for surgery, but then the patient responded very well to treatment, and then we did not need to do surgery in this case. Like I said in the beginning, 95% of all ocular allergy will require only pulse therapy, but systemic therapy is indicated when the frequent use of topical steroids outweighs the benefits, and therefore you want to avoid that. Oral cyclosporin is not only effective in controlling the acute episodes in chronic VKC, but it also reduces the need for topical steroids, and therefore it should be considered in recalcitrant disease and also in steroid-induced glaucoma or an active allergy, so patients who are steroid responder. One last aspect that I will also talk about before finishing is in those patients who present with limbal damage. And unfortunately, ocular allergy is one of the causes of bilateral limbal stem cell deficiency or chronic limbal insufficiency in India, which is very, very unusual. You don't see this in Western countries at all. So this is a study that Jayesh did many years ago, where he showed that vernal keratoconjunctivitis is one of the common causes of limbal stem cell deficiency, accounting for about a third of all cases, very high. Whereas chemical burns is usually what is most common, and immunological condition was most common in otherwise in the West. And this accounts for but it's still very rare. It's about 3% of the 1% that I talked about earlier. But when you have this, it's a very, very inflammatory condition, unlike the other causes like chemical burns, where the inflammation, there is inflammation, but it's not as severe as you see in VKC or vernal keratoconjunctivitis. And basically this growth that you see over the cornea is an extended form of what is known as a pseudoepitheliomatous hyperplasia. So it's essentially an chronic inflammatory reaction and a granuloma-like lesion that grows over the cornea and eventually stops responding to topical steroids. This is managed, you can try oral cyclosporin first, and if it doesn't go away, then these are cases that are otherwise suitable for limbal stem cell transplantation, because these eyes are wet and the underlying stroma is relatively uninvolved. Here again, oral immunosuppression is very important, because the same medication, cyclosporin or tacrolimus, is not only going to help in controlling the underlying disease, but is also very specific for immunosuppressive therapy that we would otherwise use post any transplantation for preventing allograft rejection. So here you have to understand that when we do limbal stem cell transplantation, we have to take the cells from a donor because this is a bilateral condition and you cannot take it from the other eye. In cases like chemical burns, usually one eye is affected and you can take from the other eye. So here you can kill two birds with one stone. So this, technique that we usually use in these cases is called an allogenic simple limbal epithelial transplantation. So you can see here this whole lesion from the cornea is removed. We usually put like a amniotic membrane graft on the cornea. And this is a completely sutureless procedure that you can do using fibrin glue. And this is, we are taking limbus from a cadaveric donor from the eye bank and transplanting the limbus. And this is again put in place with fibrin glue, and at the end of the procedure, bandage contact lens is placed in the eye. So in cases which have progressed to involve the entire cornea and want to restore vision, this limbal stem cell transplantation is the technique. And in these cases, it's very successful technique. You can see this is the eye before surgery. You can see how opaque the eye is because of the abnormal tissue that has grown over the cornea. And this is the same eye after the limbal stem cell transplantation, where you can see the inflammation is gone and the cornea has cleared up. The patient has near normal vision. But you can maintain this surface and prevent allograft rejection only if you put these patients on systemic cyclosporine or systemic tacrolimus. The advantage of doing this is not only does it prevent allograft rejection in the operated eye, but it also controls and the disease and progression of the keratopathy in the fellow eye. Typically, it's asymmetrical, so one eye is worse, the other eye is okay. So like in this patient, this was the fellow eye, which did not ultimately require stem cell transplantation because the same immunosuppression that we were giving for the surgery in one eye was preventing the progression of the disease in the other eye. So in these kind of blinding sequelae also, where cyclosporine may not have a preventive role, but it has a therapeutic role in sustenance of the limbal stem cell transplant, and also its beneficial effect in the other eye, which we are not operating, which is less involved. The final thought that I will leave you with, and again, I want to thank both the societies for the opportunity, is that, if this is so good, why is it not so popular? Why are not more people giving oral cyclosporine or tacrolimus to patients with chronic allergy? One reason I told you is that it's not that common. Okay, so it's common for us being in a tertiary institute referral center to see a lot of these chronic cases. Otherwise, 90% of ocular allergy is not that chronic, not that difficult to treat, and all of the modalities that were discussed earlier of using topical antihistaminics, short courses of steroids usually works. But the main reason is not popular in even in recalcitrant cases is that first of all, oral cyclosporine is not very commonly used by ophthalmologists themselves. Although topical cyclosporine is very commonly used. It's one of the commonest medications that are prescribed by ophthalmologists, but not in VKC, unfortunately, where actually it has efficacy as well. Like a lot of people will talk about tacrolimus, but not of cyclosporine, which also is very useful. Tacrolimus is particularly used, but cyclosporine is also very effective as a topical medication as well. Ophthalmologists often refer to rheumatologists for systemic immunosuppression, like, for example, in patients with uveitis or in patients with other immunological conditions. Rheumatologists, unfortunately, don't have much experience with cyclosporine or tacrolimus. They have experience with alkylating agents and with anti-proliferative agents like mycophenolate and methotrexate, but they don't really use calcineurin inhibitors that much. Calcineurin inhibitors are actually used very commonly by transplant surgeons. So, kidney transplant surgeons, hemato-oncologists, they are the ones who have experience with this. Ophthalmologists and rheumatologists, unfortunately, which is the most common collaboration in ophthalmology, multidisciplinary, the experience with oral cyclosporine is not much. So what I like to say, to my ophthalmology colleagues and also to allergy specialists, and I think that it's a great opportunity to help these patients from both sides, is to think of oral cyclosporine as topical cyclosporine, which is given orally. You take it through via the oral route. It goes into the circulation and then comes out as tears in your eyes, and it addresses the inflammation in the eye. It also addresses the underlying cause of the inflammation, which is systemic. which is not necessarily local. And you can also, look at the outcomes. Jayesh was mentioning this, the outcomes of oral cyclosporine or tacrolimus, like the outcomes that I showed you, and these are published, and there are other groups also which are publishing similar experiences. They're very similar to those that have been reported with omalizumab, although with omalizumab and with other monoclonal antibodies, the experience is less. So you can also think of it in terms of, because it's more inexpensive, as poor man's omalizumab, something that you can give, although it needs to be taken every day for a certain period of time to get the patient out of this vicious cycle of inflammation and improve not only their vision and their eye condition, but also their quality of life. Thank you so much again for the opportunity, and I'll be happy to take any questions. Thank you.
Thank you, sir, for such an enlightening session. So I was just wondering, sir, if you could touch upon any baseline workup that you do before starting these systemic immunomodulators.
So one of the advantages of using cyclosporine or tacrolimus in allergy is that most of these patients are children who have, and the dose at which you're using is not very high, not the typical doses that you use for organ transplants, and therefore they're very well tolerated, because these children usually do not have other systemic comorbidities like transplant patients have. They tolerate it very well. The main concern with using oral cyclosporine or tacrolimus is hypertension, which is almost never seen in children and not a concern. So if you want, you can monitor the blood levels of cyclosporine and see if they are within the range. You can also do regular renal function tests and liver function tests and the blood counts to check on that. We've never really had any issues with systemic tolerance or side effects of cyclosporine. And like I said, the duration for which you need to use it is also not that long, depending on the chronicity is between 6 to 18 months. And, you can then take them off. So you basically start at a dose like probably like 50 milligram BD or 100 milligram BD, depending on the weight of the child. And then you are reducing that over time and keeping it in a maintenance dose and eventually stopping it. So they're very well tolerated. Really, in terms of side effects, not much of a concern.
Thank you so much, sir. So let us move on to the case-based discussions. Our first case is by Dr. Varsha Bambani. Dr. Varsha is a trained cornea fellow and now working as a consultant in the cornea and ocular surface department at Shankar Nethralaya, Chennai. So if you could play her video. Sir, the video is not audible, sir.
Yeah.
Is there a problem related to audio?
Yes,
Yes,
sir,
doctor.
it's not audible.
Give me just 1 second. Let me try. Is it okay now?
Yes, sir, it's audible, sir.
So let me play it again. Very good evening to everyone. I am Dr. Varsha from Shankar Nitralay. At the outset, I would like to thank Indian Academy of Pediatric Allergists, AIOS, and Dr. Shweta for giving me this opportunity to present this case. So to begin with the case, a 14-year-old boy presented to us with the complaints of recurrent redness, itching, watering, and photophobia for the past 4 years. He had been under the care of a local ophthalmologist and required taking topical steroids. On examination, his best-predicted visual acuity was 6 in both eyes, intraocular visuals were normal, and the posterior segment, including the optic discs, appeared healthy. At presentation, he was on once daily rotoprednol eye drops, olopatadine eye drops twice daily, lubricating drops 4 to 6 times a day, and tacrolimus eye ointment once daily. This is the diffuse slit-lamp photograph available from his previous records, taken about 3 months ago. At the time, he had an active episode of inflammation with diffuse congestion and corner plantar spot, as we can see. He was started at that time on rotoprednol eye drops 4 times a day, and after tapering it to once, he continued once daily dose for the past 2 months. When he presented to us, the right eye was quiet, and the left eye showed only minimal activity. There was no history of systemic involvement such as rhinitis, skin allergies, or a family history of atopy. In view of the minimal activity, we advised him to continue the drops for another 2 weeks and then stop them and return for a review after 3 weeks with serum IgG testing. He stopped the topical steroids over the next week, but presented to us after 2 months with a recurrence in both his eyes. He restarted topical steroids and increased olopatadine from 0.2 to 0.7% while continuing tacrolimus and lubricating eye drops. He had not done his serum IgE initially, but when tested, the level was slightly raised. We referred him to an allergy specialist who did not find any systemic allergic compound. A skin prick test was also performed, which was negative for the common allergens. 3 months later, he again presented with an active allergy in his right eye this time. So, this was a 14-year-old boy with PTT since the age of 10. No systemic involvement, negative skin prick testing, borderline raised IgE. He continued to have recurrences every 3 months and could not be weaned off topical steroids. Each time he tapered the steroids, he would develop a reactivation in one or both his eyes within days to weeks. So in view of the steroid dependence, we decided to initiate systemic immunomodulation and started him on oral cyclosporin, 50 milligrams daily, after confirming the normal renal function tests. 2 weeks later, he again presented with active PTC in both his eyes. At this point, he was already on once daily topical steroids, tacrolimus ointment twice daily, olopatadine 0.7% twice daily, lubricating drop, and oral cyclosporin since the past 2 weeks. In view of the recurrence, we again had to escalate the topical steroids to 4 times a day, followed by a weekly tapering dose. The next 6 months, he was on oral cyclosporin, during which time also he continued to have 2 to 3 episodes of recurrent activity. At the end of 6 months, he developed rat fever and had to discontinue cyclosporin. Since he had experienced little benefits, he was not keen on restarting it. Over the following year, he continued to have recurrences approximately every 2 to 3 months. In between, his local physician prescribed oral antihistaminics, which did not help. Alcafetine was also added without benefit. He was also referred to a dermatologist to rule out atopic dermatitis, which was negative. However, because his IgE was raised, oral fexofenadine was tried, but again without any additional benefit. Despite these measures, he had to be maintained on alternate or daily FMM to control his PK. He also performed serum HIV testing, which was negative. He monitored him closely at each visit for intraocular pressure, cataract, and other complications like keratoconus. And despite his steroid dependence, fortunately, he has not yet developed any of these so far. As a next step, we have referred him to an immunologist to start him on biologic therapy, and we are yet to see how he responds to this thing. I would like to take this opportunity to ask the panelists for the insights. What should be the next step in managing this child with refractory DKC who remains steroid dependent, who has no systemic allergies, did not respond to the 6-month course of oral cyclosporin also, and has recurrences every 3 months. Thank you so much for your patient hearing. Would you like to continue with the discussion first?
Yeah, I think so, because ma'am has left us with the question to the, and she seeks
Dr. Mohan, would you like to continue with the discussion now?
Hello everyone, this is Dr. Varsha sir. Sorry for my voice, I'm having a bad throat. But I just wanted insights that what should be the next step in management of this child, because we have just sent him to the allergist specialist and he has yet to be started on the oral biologic therapy. But is there anything else that we should have done, or I just want pointers from the senior clinicians on this?
One quick comment I wanted to make, Varsha, was that, one behavioral change also that we must, and this requires a little bit of chair time, and you have to find a way to also connect to the child and the parents and to just kind of soft sell it, is also to, once you start them on the medications, initially they always respond, right? And then sometimes you can have these breakthrough episodes of inflammation. So, just like we do for viral keratitis, the prophylactic dose, you may need to adjust. So if you're using oral cyclosporin, maybe it would have worked if you had started on a higher dose and brought him down to 50. That is one. The other thing is, behavioral change in terms of trying to explain to them that they're trapped in this chronic cycle of inflammation. And one of the things that the child needs to do is to not reflexively rub their eyes whenever they have itching, and to also give solutions for that. So I will often give them like a lubricant which they can keep in the fridge and use chilled when they have allergy, instead of rubbing their eyes. So giving them also an alternative, just teach them cold compresses, and the child keeps initially get better when you give them, but if they keep rubbing their eyes, then they're trapped in this. Partly the inflammation is also caused by that, not just the disease, but this constant, like if somebody has dermatitis but they keep scratching the skin, no matter how much steroid ointments they put on that, it's going to come back.
True, sir, Dr. San, because we use quite a good dose of cyclosporin. We have not used it for ocular allergies, but if you see steroid-resistant nephrotic syndrome and all, TAC and cyclosporin, higher doses and longer duration, most of the children tolerate well. Like in this case, we've used for 6 months, but the other experts would be best to decide. But yes, a higher dose and a longer duration does not cause much side effects if you monitor it well.
What was the weight of this child? And that is one. And two is, when you started cyclosporin, did you also simultaneously start oral prednisolone or any other steroid?
No, sir. So the weight was approximately like 30 or 31 for this boy. We did not start him on oral steroids. So we just started him, he had an episode, so we just monitored that episode with a topical pulse, topical steroids, and started him on oral cyclosporin. But he developed that rat fever, and that's why he stopped it. Otherwise, we were considering to hike up the dose. And because he was on cyclosporin for that 6 months, and he did not feel any benefit, it was very difficult to, convince him that we need to put you on the systemic oral cyclosporin.
Pardon my ignorance, but what exactly is rat fever?
Sir, that's parasitic fever that he developed.
Leptospirosis or something else? Or? I don't know.
Same. Yeah.
Okay. So one might explain that, it's probably nothing to do with the cyclosporin. So
No. But
right.
his physician, his pediatrician at that point of time stopped his oral immunosuppression. And then we wanted to start it back again, but he was not we actually gave him a lot of chair time. And the next thing first thing that came to us was to start him, and probably start him at a higher dose of oral cyclosporin again and see. But
so typically my practice and what we've learned from Dr. Sangwan and everyone is to always start it with oral steroids and taper off the steroids in 4 to 6 weeks or maybe 8 weeks, because cyclosporin will take time to act. It won't act immediately. And this patient is a steroid responder, you said, or?
No, sir. No, sir. He's not a
Then you
steroid
might even
responder.
try like a depot to local steroid like triamcinolone or something like that.
Okay. 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 Thank you, sir. Thank you so much, sir.
Just a thought that came to my mind. There is some background noise here, but if you can hear me, that whether there are some conditions where the cyclosporin is not well absorbed, that is one, and whether doing a blood level might be of any use to be sure. And second is that like I have had some patients who are not compliant with the oral cyclosporin. So uh, like they say they're taking, but they were not taking in the right dose, or the child has been skipping. So they may still not get good control. They're just two thoughts that came to my mind. Maybe we could look into that.
Thank you,
But-
sir. That's a very good point. Yes, sir.
But as ma'am said, 31 kg, so 100 was not a very low dose also, like for that child. Like 3, and maybe this child is not faring well also. 14 years, 31 kg. This child has some.
I just wanted to check if you have any experience of using JAK kinase inhibitors in these cases.
No, ma'am. I personally do not have any experience for the JAK kinase inhibitors, ma'am.
Okay, thank you.
I think if I can add on to this case, sorry, my camera is somehow Zoom is not detecting. But as Dr. Sonia was telling, I think cyclosporin does take sometimes in refractory patients for us to take more time to respond. Because sometimes if it is local allergic reactions which may not have been showing up on the skin prick test, I think it's worthwhile repeating it. Say now it's 6 months down the line, he's on oral cyclosporin. Even in spite of high dose of cyclosporin, I would probably revisit the history and probably try to check, do a repeat skin prick test. Say after 1 year, you have he's on cyclosporin, and to see if there is any newer sensitizations. And if that matches his history, then probably explore other treatment options also. And probably biologic, if it is refractory to everything, I think biologic would be the ultimate resort. We would probably keep it in our armamentarium.
Ma'am, we had a discussion yesterday about if the skin prick test is negative, we can do a conjunctival stimulation test. Any role of that to find what is the local allergen that he is sensitive to in such a case? And would like allergen immunotherapy in that case be helpful? Just out of curiosity, ma'am. Like.
No, I think the conjunctival challenge test or the nasal provocation test we would possibly consider in the background of local allergic reactions. I think it is a starting point of the probable systemic reaction later on. So I think even if it is conjunctival provocation test would have been positive, probably at that point of time an allergen immunotherapy, he may not be a good candidate yet.
Okay. Thank you.
That's only for diagnostic purpose. We wouldn't be using it for the allergen immunotherapy prediction or a suitable candidacy.
Thank you so much. Thank you, everyone. Thank you so much.
Thank you so much, Dr. Varsha. And now we come to the second case. The second case will be presented by Dr. Prajakta Dandekar. Dr. Prajakta is a trained cornea fellow from LV Prasad and has served Army for almost 15 years. She's now working at Shantilal Sanghvi Eye Institute as a faculty in cornea. And a warm welcome to you, Dr. Prajakta. You can start presenting the case.
Thank you, ma'am.
I'm Dr. Prajakta Dandekar, cornea faculty at Shantilal Sanghvi Eye Institute in Mumbai. I will be presenting a case of vernal keratoconjunctivitis. My patient is a 15 years old male child who gave the history of itching and rubbing in both eyes. There were findings of cobblestone papillae, limbus stem cell deficiency, and viral keratitis noted in his blood. He was on sodium hyaluronate and carboxymethyl cellulose hydrox for a year and has recently stopped them since last 1 year. There was history of recurrent on and off redness in both eyes. There was no history of any seasonal variation. There was no history of any surgery done. In ocular examination, the best corrected visual acuity in the right eye was counting towards 2 meters, and in the left eye it was 20 by 125. In the right eye showed evidence of keratopathy with 360 degrees sevous vascularization, but no obvious conjunctivalization with whitish plaque-like deposits of lightly keratin on the corneal surface. The left eye, there was conjunctival congestion as compared to the right eye. The panels extending in the superior one-third of the cornea, with vessels extending beyond the panels. There was an epithelial defect of 3.5 into 2 millimeters with well-defined margins and a central infiltrate with surrounding stromal piece. There was no obvious AC reaction or hypopnea. The eyes appeared wet in both eyes, and the direct assessment of tear secretion showed 2 ducts in both eyes with spontaneous flow. These are 2 other images of the left eye in down gaze, showing conjunctivalization in the superior part, and the optical section image on the right, showing involvement of the anterior stromal surface. The upper tarsal conjunctiva, there was pigmentation and scarring with a few papillae visible in both eyes. One prominent papilla was visible in the superior tarsal surface of the left eye. It is doubtful whether that alone was responsible for the ulceration in the left eye. But grossly, there were no papillae in purposeful appearance visible at the upper tarsal conjunctiva. These are the anterior segment typical coherence tomography images of both eyes. The right eye shows scarring almost involving the mid stroma, and the left eye shows the epithelial defect and just the anterior stromal involvement. So, we diagnose the patient as having chronic sequelae of vernal keratoconjunctivitis in both eyes, with right eye showing common keratinization and scarring, and left eye showing shades also. And we wanted to rule out microbial keratitis, so we decided to investigate by doing stings in the left eye, which revealed no organisms. Both eyes were started on tacrolimus by 1.8 mg and with fresh tears at a carboxymethyl cellulose 6 times a day. For the left eye, we started the patient on moxifloxacin 0.5% every 2 hourly and also bromide 2% twice daily. And then the right eye, we started prednisolone in tapering dose starting from 6 times a day. Certain significance showing Haemophilus influenza, which was again susceptible to glutamate. The patient was followed up after 1 week, and there was significant improvement in the visual acuity in the left eye and reduction in the size of the epithelial defect. At this visit, we also planned for amniotic membrane grafting in the left eye, and we referred to the pediatrician for starting oral steroids as well as immunosuppressant therapy and to rule out vitamin B deficiency. At 2 weeks follow-up, the systemic investigations were undertaken. The absolute eosinophil count was 89.5. The serum vitamin K levels were normal, and the patient was started on cyclosporine 50 milligrams once a day, along with topical and oral steroids. The patient's vision improved significantly in the left eye, and this is the latest picture taken after 3 months, in which the vision is 20/20 with a healed shield as well. With the right eye, the status remains the same. He still has keratinization, and there is no improvement in the vision. The Shermer's also shows was more than 35 in both eyes without parent. So currently, the patient continues to use tacrolimus, refresh tears, and tablet cyclosporine, and he's on alternate day luteprolol in both eyes. So these are the questions for the panelists. Have you encountered any such case of corneal keratinization in VKC in a wet eye? And do you think that long-term immunosuppression will help in its resolution? Thank you.
Projector keratinization, nice case. Keratinization in in VKC, the cases that I've seen are all because of the topical medication induced, like topical drug induced inflammation. But a lot of most now, of course, is different, but typically most anti-allergic medications earlier used to be with BAK, still are. A lot of these allergy patients also use on their own and sometimes over-the-counter topical decongestants. So just make sure that they are not on those things or they don't self-medicate with that. And keratinization usually is there. So in cases of chronic inflammation, VKC, where you see keratinization, try to give them as preservative-free topical medication as much as possible. Systemic is also fine.
Yes.
You're mute, Bhaskar.
The other reason for the keratinization also, it's going to be a very severely damaged surface. Sensations are less, epithelium is irregular, it's probably a little bit hypertrophic. So even though you have tears, the tears are probably not coating the anterior surface. Now the eye has now quietened down with the effect of lubricant, so we'll probably give it some time to see how much of it kind of reverses. Otherwise, maybe even just doing a temporary tarsorrhaphy, you might probably see if it is related to the tear film and exposure related changes, that might improve over a period of time.
The immunosuppression therapy needs to be continued in this patient. Otherwise, but it has it any role for keratinization?
Not for the keratinization, but at least the fact that the disease is under control, the inflammation part settles down. The keratinization is probably because it already was a hypertrophic epithelium, which is kind of jutting out a little bit. If you look at the child, you'll probably he will have decreased blink, you would have incomplete blink. There is going to be loss of sensations because of the chronic inflammatory states. So once the inflammation is under control, those changes will probably revert to a certain extent as best as it can. Once that happens, we'll be able to see an improvement in the ocular surface status.
Thank you.
So thank you so much, Dr. Prajakta, for such a wonderful case. And I think this brings us to the end of the 2 hours of extensive eye-opening learning with such legendary, I would say, faculties who are like authorities in their field. And it was such a learning experience for all of us, as well as the delegates, the people who are watching in YouTube. And before I invite visionary chairperson, Dr. Neeraj Gupta, for the vote of thanks, I would like to thank each and all of you, and especially Dr. Neeraj Gupta, to make us a part of this learning journey. So a warm welcome to you again, Dr. Neeraj, and I would hand over the stage to you for the vote of thanks.
Thank you very much, Dr. Sonia Bhatt. So I think this was one of the sessions which I was looking for I think, sometimes long. And it was really, really very good. And I think means like each and every person seems to be, you can say, like jewel in itself. They are expert in itself. And when all the experts came together, I am very much special thankful to Dr. Nikhil, Dr. Jayesh, Dr. Bhaskar for all their inputs. And simultaneously, what a fantastic opening by Dr. Sharon regarding the topical therapy in ocular allergies, the way she navigated everything. And then later on, it was complemented by Dr. Senchana about the systemic therapies and including biologics. And the way she clearly mentioned that which biologic, what is the indication, where it should be used, where it should not be used, and who should use it. So very clear. And then thereafter, the masterpiece which was delivered by Dr. Soumya, as always, in the form that when pharmacotherapy along with immunotherapy. So when these two things can go hand in hand together, then at that time, how the things can be much more beneficial, and ultimately we can really provide the quality of life or improve the quality of life. And Dr. Sen Basu is just, I do not have any words for him. He is such a fantastic person. I was fortunate to meet him in person 2 months back. Fantastic personality and the fantastic speaker, fantastic orator, world-class speaker, spoke on systemic immunomodulators, immunosuppressive and ocular allergy. Overall, I was like for past 2 hours, I was completely, you can say, like stunned, listening, all those things. And then I think 2 beautiful ladies, Dr. Sonia and Dr. Madhuvanti Mohan, beautifully navigated each and everything. So I think means I cannot just expect anything better than this particular webinar today. And thank you, everyone. Thank you very much. And then tomorrow we will be having the 3rd part of the webinar, and in which we'll be discussing a little bit more advances about the ocular allergies. Once again, I would like to thank IAP allergy chapters and simultaneously All India Ophthalmological Society and all the people who have made it possible. A special thanks to my dear friend, Dr. Shweta, who was like on a single call, even half of a call, she was immediately available, and then she arranged each and everything so beautifully. So thank you very much. Thank you. Thank you, everyone. Thank you.
Thank you.
Thank you all.
Thank you. Good night.
Thank you, sir. Thank you, everyone.
Thank you, everyone.